Good morning. My name is Kevin Wu, research fellow with the Restore Lab in the Institute of Surgical Research in San Antonio. This is our disclaimer, and I have nothing else to disclose. So in the past 15 years, warfighting gear and technologies have consistently improved, which have dramatically reduced severe injuries to vital organs. However, there is still exposed faces and extremities that will suffer severe injuries that are not reconstructable with our current surgical methods. Advances in prosthetics can help offset some of the burdens of survival, but the amputees will never regain complete form or function. This is a graph just to reiterate the point that since the advances in trauma care since 2006, there has been decreases in deaths, but there's an increase in injury severity, which means that most of our soldiers are surviving these debilitating injuries, but these injuries are beyond the capabilities of our classical means of repair. Therefore, vascular composite allotransplantation can be a new reality for these service members. VCA transplants such as hands and faces you may have seen in the media has advanced rapidly in the past 2 decades. With wider adoption by multiple centers and progressive immunosuppressive protocols, they have proven the technical attainability of these procedures. However, with its success also comes along with its challenges, and I'm going to focus on our talk today on systemic immunosuppression. With the current immunosuppressive drug regimen that's similar to solid organ transplants, the immunosuppressive drug regimens will cause toxicity and generalized immunosuppression, and the transplant patients will be vulnerable to opportunistic infections and certain types of malignancies. Now, if you offer a kidney or a transplant for these patients, there's usually no ethical dilemma with a life-saving transplant. But if you do a transplant such as VCA, which is a life-enhancing procedure, and you risk the patient's health with immunosuppression, then many critics will speculate on the necessity for these procedures. So our focus is to prevent the acute rejection process is by using an implantable tacrolimus-eluting hydrogel. And the advantage of using these gels is that they can serve as a drug delivery vessel that's resistant to the normal biological environment, but activated by macrophages in the inflammatory or rejection process, and so that the carried drug is delivered locally and potentially avoiding systemic toxicity. We have shown this to prolong graft survival in our porcine allotransplant model shown here, where we use adult Yucatan swine weighing between 70 to 90 kilograms. As you can see, a myocutaneous flap is harvested from both animals, shown in the green and the blue, and each animal will serve as a donor and recipient for each other. Each donor-recipient pairs were one swine leukocyte antigen mismatched, which means that's similar as a human receiving an organ from a living related donor. This is an image or diagram on the right of our preoperative markings. And the image on our left is the skin island created and the semitendinosus muscle just beneath that, where we'll dissect down and we'll visualize our vascular pedicle, where you see on the green arrow, and then the image on the bottom right is our isolated flap with the attached artery and the vein. Simultaneously, while we harvest the flaps, we make a midline incision in the neck, and we dissect through the strap muscles where we'll arrive at our recipient site, and that's where we'll perform our end-to-end anastomosis to the carotid vessels. And the image on the left is our microscopic view of our anastomosis, and once we set the flap into the neck, and we can suture the skin island to the surrounding skin of the neck. For our experiment, Group 1 controls received no drug intervention, and in Group 2, our experimental group, they received a tacrolimus-eluting hydrogel, which was injected subcutaneously into donor flap immediately before end of ischemia time. Tissue and blood samples were collected for tacrolimus levels, and grafts were assessed for rejection until the endpoint of grade 4 rejection based off the Banff rejection scale. Here's our Banff grading system, where you can see the histology on the image on the top left will show no mononuclear infiltrates, and clinically you show on the skin to be normal or somewhat erythematous. And on the opposite end of the spectrum, grade 4 rejection histology will have diffuse mononuclear infiltrates and frank necrosis of the epidermis. Here's our appearance of our flaps, where they will progress generally to a necrotic appearance by post-op day 14. And the red box surrounding these images represents how the flaps will look histologically, or the day when they first reach grade 4 rejection. Shown there as well. Animal 5 reached grade 4 rejection, the latest at post-op day 37, and animal 6 actually reached grade 4 rejection on post-op day 7, the earliest, and this is due to ischemia, not rejection, based off of histology, where we see very minimal mononuclear infiltrates. This is our Kaplan-Meier curve, where we show that on the control flaps, the flaps reached grade 4 rejection on an average of post-op day 7, and the treated flaps will reach grade 4 rejection on an average of post-op day 21. And looking at our tissue tacrolimus levels, all of our flaps will generally have exhausted their tacrolimus gel or tacrolimus drug by post-op day 7. And looking at the blood levels, which were well below toxicity, they will become minimal by post-op day 21. And when we look at the tissue tacrolimus levels, when it exhausts by post-op day 7 forth, we can attempt to correlate this with how these flaps look from that starting point, where we can notice scaling or erythema, and combine that with our tacrolimus levels, we can attempt to reload the gel and prevent the flaps from dying. So in conclusion, donor graft tissue-specific immunomodulation with drug-eluting compounds can be a helpful component for VCA to avoid the use of systemic immunosuppression and avoid its complications. And the view of the tacrolimus levels can help us with the appropriate time to reload the gel, and also help us prolong graft survival. Thank you for your attention, and I can take any questions at this time.
We'll take questions from the floor. I have 2 questions for you. Have you looked at any multimodal therapy with other medications in addition to the tacrolimus? Mm-hmm. And then I guess you alluded to it briefly. Have you thought of obviously injecting tacrolimus again? And mm-hmm. Can your animals get a weekly dose or something mm-hmm. like that?
Right. As of right now, we're not experimenting with other drugs, but we have used rapamycin with microparticles in the past. That has also shown to prolong the survival, and there's also we try to extend it further by using the MMFs or other induction therapy, but we are just focusing on tacrolimus right now because that seems to be what's translatable to the clinical regimens that they use. And in addition, with pulse therapy, if there is rejection in the clinical setting, they'll use prednisone and whatnot. And so as of right now, we're planning our protocols to redose the gel sort of at the time point we see, and I'll show you, can I go back on this? Yeah, so starting on post-op day 7, we'll start to see clinically where we see that scaling in erythema, and we can kind of correlate how the tissue tacrol levels have depleted at that point, and we can start redosing at that point. But what we have done, we tried in a model where we've redosed it, but being they're immunosuppressed, they'll tend to pus out like the gel. So we're trying to keep them on a very strict antibiotic prophylaxis so that we can, because they're already immunosuppressed, so we're just trying to redose it and keep that flap from rejecting.
Great, thanks.